India, Professor Dr. Arvind Kumar. He is currently the chairman of the Institute of Chest Surgery, Lung Oncosurgery, and Lung Transplantation at Medanta. A lot of people these days they confuse between a chest surgeon or a cardiac surgeon. So can
And yes, to as the first ball of the match, question which you have posed to me is very pertinent, very practical, and often asked. Thoracic surgery training program, they'll have to have an experienced thoracic surgeon heading the program with academic credentials to be given an academic program. That's what you need. So what we have is a 3 years very rigorous, very intense, very hard. It's very hard training program. We at present do roughly 100 cases. Patients are assured of the best care. The students are assured of the best teaching, and we are assured of the best experience.
right. It's a
Thoracic surgery centers.
But so with these respiratory problems that is emerging and it increasing in India, don't you think that 7 seats are too less to be trained?
In fact, less is the wrong word.
Is it?
Less
is an understatement, I think.
So, when we have surgeries, we have complications, plenty of them. But we know how to manage them. Sometimes they are successful, sometimes they are not. We're not saying that we are a super
in this branch, because I see primarily the centers are only in North India. It's only one that you mentioned in Bangalore and one in Patna.
Theoretically, yes, these centers should get replicated.
Right.
But there is a practical issue.
Question in terms of the medical field is that now if a doctor who would want to do this specialization in thoracic surgery, controversies around NEET UG and NEET PG. So before you take up that candidate, how would you ensure that the qualification is legitimate?
And they're aware that it's going to be a hard life. We consultants also spend about 13-14 hours in the hospital, so fellows that will spend more. They know it's a tough life, it's a hard life. But it's just the thoracic surgery. When you look at next 20 years horizon, there is going to be a massive patient load, because old world diseases like TB. It's not that there are hospitals where there may be huge volume is there. Nobody is there to supervise. So जिसकी जो मर्जी आती है वो करता है. Here किसी की कोई.
Hello and welcome back to NH Talkshow, a show where we explore the world of health, wellness and medical breakthrough. Today we are honored to have one of the most respected and reputed chest surgeons in India, Professor Dr. Arvind Kumar. He is currently the chairman of the Institute of Chest Surgery, Lung Oncosurgery and Lung Transplantation at Medanta, Gurgaon. So let's just welcome him, because I'm very excited to meet him. Sir, a very warm welcome to NH Talkshow. We are a health channel, so thank you so much for joining us today. And to begin the show, I would request you, because a lot of people these days they confuse between a chest surgeon or a cardiac surgeon. So can I please request you to break this myth and tell us what is the difference between these two surgeries?
Sure. So first of all, Mayank ji, thank you so much for inviting me to this show. I know I've been watching a few of the episodes of your shows,
Thank you so much, sir.
Truly you are a health channel which is providing a very high quality, filtered and verified kind of health information. On the internet there is a lot of garbage also available in the guise of information, but you are giving very focused and precise information. So thank you so much for inviting me to this show. And yes, as the first ball of the match, the question which you have posed to me is very pertinent, very practical and often asked to me. What is the difference between a cardiothoracic surgeon, cardiac surgeon and a thoracic surgeon? So in chest we have heart in the middle and two lungs on either side. Historically, when this surgery in the chest started, the heart surgery started after the lung surgery, but heart surgery was the kind of glamorous part. So they kind of became well known, and many of them were doing heart as well as lungs. So cardiothoracic, cardiac means heart and thoracic means the
Lungs.
lungs. So cardiothoracic word became popular, that he is a cardiothoracic surgeon. But as this field progressed, it was realized that actually these are two very different branches, and specialist in one need not be a real specialist in the other also. So in US and in Europe, sometimes in mid 60s or late 60s, they started branching out as cardiac or
And
thoracic.
thoracic.
So there was a cardiac surgery and thoracic surgery. As a matter of fact, when it started, even the blood vessels were part of this. So it used to be called cardiothoracic vascular surgery, CTVS, or some people will call it CVTS.
So,
But heart, blood vessels, and lungs, these were clubbed together.
when was this? What year was this, sir?
So this was sometimes in 60s. It happened in US
1960s.
and Europe
Right.
that people realized that no, these are three entirely different
Different.
specialties which unfortunately got clubbed together, but they need to be separate. So the vascular was separated out, cardiac was separated out, and in US and Europe, thoracic
Thoracic was
surgery
also.
took off in a big way. So 70s onwards, if you see, they will have a division of thoracic surgery, division of cardiac thoracic surgery, and division of vascular surgery.
Right.
In our country, this marriage continued till very recently, and that's why somehow the thoracic surgery did not develop in our country, because this cardiac and thoracic separation did not happen, neither at rule governing bodies level, like we have Medical Council of India, National Board. Neither it happened at their level nor it happened at the ground level. So the departments across the country in medical schools continued to be cardiothoracic department. Of course, the vascular
Vascular was
separated out
separated.
much
Okay.
earlier,
Okay.
but cardiac and thoracics continued to be together. And so this was the status. So I was at AIMS and I was doing thoracic surgery in general surgery department. And when we left and joined Gangaram, we reached out to the National Board of Examinations saying that a time has come where thoracic needs to be identified as a standalone specialty separate from cardiac surgery. This was around mid of 2012 that
So
we
it's very
gave.
recent.
Very recent,
Yeah.
very recent. So we gave this request to the National Board, and National Board was very kind, very progressive in its intent, and after about a year of lot of paperwork, lot of documentation, and lot of meetings, finally, sometimes in mid 2013, they approved thoracic surgery as a standalone specialty separate from cardiac surgery, which paved the way for me to bid for start of an exclusive thoracic surgery super specialty training program. And I'm happy to say that with grace of God and blessings of my teachers and parents and other elders, January of 2014, when we were at Sir Gangaram Hospital, our department was the first department in the country to start a post MS surgery 3 years super specialty program in thoracic
Thoracic.
surgery, which has continued since then with us. And when we moved to Medanta, the program also moved with us. And today we have a vibrant program with an annual intake of three postgraduate super specialty
Specialty.
doctors after their MS surgery. So we have six fellows, we call them fellows, six fellows because they are post residency programs. So six fellows in position, and in the next 1 month, three more, the current batch will be joining soon. So after that, few other centers across the country have also received this
Started this.
program.
Okay.
Very few. So total number of seats across the country are just about the same as the number of seats we have.
In Medanta.
We have 3 seats. So there are 3 other institutions in the country which have one seats each.
Okay.
So total of about 7 or 8 seats in the country, out of which three
In
seats are
totality.
with us in total. So you can imagine that even today,
Right.
despite thoracic surgery being identified as a standalone specialty, the teaching program is just limited to 3 or 4 centers for a population of 140 crore, whereas there is huge number of patients in the community, and majority of the centers continue to be, even today, cardiothoracic surgery centers, where 99% of the work is cardiac. So the students are taught cardiac, they see cardiac, and when they go out and set up their practice, they do cardiac, and thoracic continues to be neglected.
But sir, you saying that we have only 7 seats in all India. So where do you see currently? Let's talk about the other hospitals. Do you think that they have this specialized branch in all the hospitals? So where do we stand at the moment?
So for any hospital to be able to start a thoracic surgery training program, they'll have to have an experienced thoracic surgeon heading the program with academic credentials to be given an academic program. That's one.
Yeah.
And they have to have a good enough volume for them to be recognized as a training center. Now, this requirement is difficult to meet because, as I said, most of the people in the country are cardiothoracic surgeons. Not many people have ventured into the field of exclusive thoracic surgery as we have done.
But I also understand that a lot of doctors attend this fellowship program wherein they go to different hospitals and do this fellowship program with other senior doctors who train them in that. So do you think that sort of process will also help other doctors become specialized in this, or
no? These are not fellowship programs. These are actually visitorship.
Okay.
People just visit for few weeks, and you can't become a thoracic surgeon
Yeah.
by visiting a center for few
For a
weeks.
few
So what we
weeks.
have is a 3 years, very rigorous, very
Specialized
intense,
program,
very hard.
Yeah.
It's very hard
Yeah.
training program. We at present do roughly 100 cases a month. So that converts to nearly 2.5 to 3,000 cases a year.
Yeah.
And in 3 years' time, the children will see about 8, 9,000. Okay, maybe few months leave, at least 7, 8,000 cases they would have seen. So that's the kind of training we are giving to them. I don't think many centers can match that training. The volume, variety, we do open surgery, we do video assisted thoracoscopic surgery, we do robotic surgery, we do lung transplant, we do bronchoscopies, we do bronchoscopic interventions. So you name a procedure in thoracic surgery and we do it in adequate numbers, in a very structured way, the way it should be done. Not that the stress, despite having good quantity, the stress is still is primarily on quality. So we deliver quantity with quality assured. Not that in the process of increasing the numbers, the quality is thrown to the wind. No. Quality is assured, only then we let the numbers increase. If we could throw the quality to the wind, I think the numbers would probably get doubled of what they are, but we don't want that. We want to maintain quality and still go on slowly increasing the numbers. So patients are assured of the best care, the students are assured of the best teaching, and we are assured of the best experience.
Right. It's a very good subject, sir, that you started. I don't know whether you can disclose this or no, but I understand Medanta is one institute. And I'm assuming because it started from Sir Gangaram, so that's number two. Do you think that you can name the other centers as well?
Sure.
Yeah.
So as of today, we have 3 seats at Medanta, and Gangaram has 1 seat. The National Institute of Tuberculosis and Respiratory Diseases at Maroli, which was earlier known as LRSTB Hospital, has a seat.
Okay.
And Narayana Hridayalaya, Bangalore, has a seat, and AIMS Patna has also been sanctioned a seat, but I believe last 2 batches, no one has taken that seat.
Okay.
Children also will look at the training and other aspects when they pick up the seat. So that's why I said that about 7, 8 seats. It's not to say that there are not CH in other colleges. There are more than 100 MCH seats in other medical colleges and equal number of DNB seats, DNB cardiothoracic seats in other teaching hospitals, private hospitals across the country. Those are all cardiothoracic,
Right.
where 98%, 99% of the work is cardiac.
Not thoracic.
I'm talking of
Mm.
exclusive thoracic surgery centers. We do no cardiac. So these are exclusive thoracic surgery centers.
But sir, with these respiratory problems that is emerging and it increasing in India, don't you think that 7 seats are too less to be trained?
In
And
fact, less is a wrong word.
is it
Less.
less is an understatement, I think.
It's like a drop in the ocean.
Yeah.
This country needs at least 100 seats a year.
Yeah.
We need a thoracic surgeon and a thoracic surgical unit in every district. In fact, just a year back, I gave an oration in the Association of Surgeons of India annual conference. It's called Colonel Pandlai Oration. And my topic of the oration was why India needs a thoracic surgery unit in every district. Because there is a humongous amount of patient load in every district. So we need, in every district. But
Right.
leave aside district, today we have whole of states which are bereft of any organized chest service. I'd like to make a difference because many people might feel that I'm stating wrong because, so there are two things. One is somebody doing thoracic surgery and other is a well organized thoracic
Specialized
surgery
surgery.
center.
Correct.
Let me make this difference clear. When I'm saying these are only 7 seats and few centers, these are well organized, dedicated thoracic surgery centers. But other than this, there is thoracic surgery happening in every district, even today. There are general surgeons who
Of
are doing
course,
thoracic
yeah.
surgery, there are surgical oncologists who are doing thoracic surgery, there are cardiothoracic
Cardio.
surgeons who are doing thoracic surgery, but none of them is a structured, all encompassing, full fledged thoracic center,
Specialized center.
specialist center. They
Right.
would do 100 gallbladders also, hernia also, and maybe twice in a month. If somebody comes, they would do a surgery also.
Right.
Now, this cannot become a training center because they do it. But when there are problems,
They're not specialized.
they're not
Basically.
specialized, and when there are problems, they don't know how to get out of it.
Right.
And we face this problem because there are a lot of, so when we look at our volume, 10 years back, our volume was mostly primary cases. But as the years are passing by, we are now having an increasing number of referred cases who have already been operated outside and had a problem which was not possible to manage, and now they are sent to us. So what I'm saying is that they do. Some patients get all right also, but some don't. And when they don't know what to do.
Right.
Which is not the best of things. If you do a surgery, you must know ways of getting out of every possible complication of that surgery.
Right.
So when we have surgeries, we have complications, plenty of them, but we know how to manage them. Sometimes they are successful, sometimes they are not. We're not saying that we are a superhuman center. We are a very much human. We have our own good quota of complications, deaths, everything. Any center which takes up complicated cases will have deaths and complications.
Right.
But everything happens in a very SOP based format and not a haphazard format, which is how it happens across the globe.
I agree with you.
You
sir.
go to the best
Yeah.
end. I mean, I've been to every possible well-known center across Europe and US, and they also have problems. They also have complications. They
Of
also
course.
have deaths.
Yeah. Yeah.
So our results are not second to any well-known center anywhere in the world. They are as good as, or sometimes in some areas even better than, because there are some areas which are more seen in our part of the world.
Right.
And we have much larger volumes. We do say 50 cases in a month, and they do maybe 5 in a year. So in those areas, our results are much better than theirs.
correct.
But there are other areas which they do more, where we are doing equally well.
Yeah.
So this is what I'm referring to as an exclusive thoracic surgery center, doing high-end work in a SOP-based format,
Mhm.
all encompassing. You do clinical work, you do teaching, you do research, you write papers. So everything under one roof, a complete center.
Yeah. Um, as you were just mentioning, sir, I think you were one of the board members who started this from the grassroots in Sargangaram, right?
Not a board member. I was a thoracic surgeon. So I was uh, chosen by Gangaram Hospital to start a thoracic surgery department. So when I quit All India Institute of Medical Sciences, I joined Gangaram. They had given me an option of either joining general surgery department
Or
on continuing to do general surgery and thoracic surgery also,
right,
or set up an exclusive thoracic surgery department, which means I'll have no general surgical rights, only
only the
thoracic
thoracic.
surgery. So my purpose of quitting All India Institute was to start a thoracic surgery program. So there
Right.
was no question of my joining general surgery. So I chose exclusive thoracic surgery, where we did only thoracic surgery. We got the training program. We did a lot of research also. We wrote a lot of papers also. We trained surgeons, even outside of a structured training program. Like one is the DNB program. Even otherwise, we do regular CME programs for doctors, for surgeons, for nurses, for other paramedics. So teaching has been an important part of our overall portfolio.
Yeah. No, so what I'm trying to ask, sir, that you've been a great support who has started this thoracic specialized branch. So do you think that you can also contribute in some sort of increasing these centers so that more and more doctors are they get specialized in this branch? Because I see primarily the centers are only in North India. It's only one
Yeah,
that you
yeah,
mentioned
yeah.
in Bangalore and one in
Yeah,
Patna.
theoretically, yes, these centers should get replicated.
Right.
But there is a practical issue. You need very experienced teachers to be able to man these centers. So from where do you get these experienced teachers? Because so we have now we started with two, me and my colleague Dr. Bilal in Gangaram, but then we had our own students passing out and joining us. From two, we've grown to a 6+2 today. So we are six consultants, and two of our students who've just passed out
Hmm.
have joined as associate consultant. They'll become consultants in a year or two. So we have 6+2. So from two, it's grown to 6+2. It's here.
Hmm.
Now we are growing here. Medanta has branches coming up in various parts of the country. So we
Correct.
have a branch already functional in Lucknow, in Patna, Indore. So we are just waiting for some more strength to get added to our group, and then we'll have some of our people shifting to those locations.
Hmm.
We have a unit coming up at Noida. We'll be shifting 2 or 3 people to Noida. And then we have units coming up Mumbai. Now something is coming up in Guwahati as well. So as the years pass by and my current students join me as consultants, we'll be shifting out to these locations, because these are people who have received a very hardcore thoracic surgery training of high volume cases, all types of cases, including post-operative problems and their management.
Hmm.
So they are complete trained thoracic surgeons. Now,
Surgeons.
this kind of complete thoracic surgeons are not a very common entity in the
Right.
country. And in the absence of that, if you open centers and you don't have people who can do all the
Perform.
cases,
Yeah.
and you take students, then you are bringing out half-baked students,
Yeah.
so that's why it will grow, but it has to grow slowly. It
Hmm.
cannot be an overnight mushrooming of thoracic surgeons, because it's a tough branch. The margin of error is very small. If you do a mistake, patient pays a heavy price for
Correct.
that, often
Yeah.
with his life.
Yeah.
So therefore, while planning development, the quality has to be assured, and that's why a development cannot be fast. It has to be slow.
Right. I think currently we're only talking about in medical terms, not relatable to the general public. But I still have one more question before we jump on to something or information for our general audience. So that one question that I have, the last question in terms of the medical field, is this: that Now, if a doctor who would want to do this specialization in thoracic surgery, what are the criteria? Because when a let's say when a student chooses to be a doctor, they do need UG and need
Yeah,
PG.
yeah,
So, what are the criteria
sure.
that you have
Yeah.
for this?
So our intake is through the NEET super specialty program of the National Board of Examinations. So, and the prerequisite qualification is to have done either a master's or a DNB in general surgery.
In general surgery?
So, all those who have completed their MS or DNB in general surgery are eligible to apply. They have to take the National Board's NEET super specialty exam, and thereafter there is counseling. So, our seats are advertised in the matrix in advance, so they have to apply, and then depending on the merit, they would be allotted the seats.
Uh, Again, sir, one more question just cropped up my head that uh, you know I we keep hearing, general people, we keep hearing a lot of uh, controversies around NEET UG and NEET PG. So before you take up that candidate, how would you ensure that uh, the qualification is legitimate for that candidate?
So that's and beyond my purview.
Okay,
I am not a statutory body of the government of India.
I agree.
Neither I have the means and the capabilities to be verifying the correctness of the UG or PG or super specialty course.
Hmm.
That's an area government has to fix. For me, National Board is a standard examination body. I have to presume that their examination is of highest standard, merit based, and whatever merit list they have prepared is sacrosanct. And whoever gets the seat as per the merit is hopefully the best
Correct.
amongst the available ones.
Yeah.
These are presumptions which I have to necessarily accept because these are anything in this domain is beyond my purview.
Mhm.
So till date, we've had wonderful. We have never had a chance to regret. All those who have joined, actually, since it's an uncommon branch, so the children do a lot of background search before they come.
Okay.
They know about us. They reach out to us or to our students. They talk to them. In fact, recently, one of the surgeon from a neighboring hospital um, came here and he spent 24 hours with a fellow of mine who was on duty just to get a first hand of experience how it feels to be doing a 24 hours duty in this field. So he got a first hand experience and he thought that yes, he's meant for it and the specialty is meant for him, so he's now attempting to get a seat. So when
Okay.
you have these kind of children who are coming, they're not coming blindly, they
They
do
do their
search
research
and then take an informed
decision.
decision,
Yeah.
and they're aware that it's going to be a hard life. We consultants also spend about 13 14 hours in the hospital, so fellows have to spend more. They know it's a tough life, it's a hard life, but then if you like it, it's fun.
Right. Right. I think so. This is the end of the doctor session because a lot of doctors can see and have this information about thoracic surgery. Let's move on to our
So before we close this session,
yeah,
since you're talking, let me give a very clear cut message. The thoracic surgery, when you look at next 20 years
horizon.
horizon,
Yeah.
there is going to be a massive patient load because old world diseases like TB still exist.
Yeah.
Now, a lot of people say, oh, government is after TB in the next 5 years. In fact, 25 was the target, or
Target.
maybe 30. In next 5 years, TB will be eradicated. Yes, TB will be eradicated, but there's a huge volume of post TB problems which need surgical intervention. In fact, we rarely operate for TB. Whenever we operate in the domain of TB, it is for post TB complications rather than for TB itself, which is primarily treated by medicine.
Mm.
So even if you will eradicate the TB today, the next 25 years will continue to have a humongous volume of post-tubercular complications which will need surgery. So this group is and will be there, number one. Number two, cancers are on the rise because of pollution, smoking, e-cigarettes and what have you. Cancers are on the rise. So that's the second load. And third, whether it's a good development or bad development, trauma is on the rise. Especially trauma, not stress, accidents.
Okay.
And chest is an important area which is injured. And that again is something which is increasing in numbers in the last 10 years. So you have inflammatory diseases, you have cancers, you have trauma and various miscellaneous diseases. So overall, there's going to be a huge patient load in the next 15 to 20 years. So if a student was deciding today, I mean, he would be looking at next 20 years horizon. So he can be assured of huge patient load in the next 20 years. One. Two, when it comes to training, we have more than 100 cases a month, which is about 1,000 plus a year. And in 3 years, you'll see nearly 3,000 cases, open, VATS, robotic, lung transplant, this, that. Everything is there, from simplest biopsy to the most complicated lung transplant. Everything is there. And most importantly, everything is done in a very strictly quality controlled, supervised, SOP based method. It's not that, there are hospitals where there may be huge volume is there. Nobody is there to supervise. So, जिसकी जो मर्जी आती है वो करता है. Correct. Here, किसी की कोई मर्जी नहीं चलती. We have discussions. It's like commando operations. We have a action room. Discussions take place. Decisions are taken, and once decisions are taken, they have to be enforced with commando-like spirit. Nobody can move a millimeter from what has been decided, because that's vital for the recovery of the patients. If everybody is at his will to do what he wishes to do, surgical unit cannot function. Correct. So if you join this department, you will be assured of world's best quality training, and you will come out as a thoracic surgeon, complete thoracic surgeon.
I'm sure, sir, with your vast experience and the confidence that you have for this branch, a lot of doctors will take up this specialized course.